Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Welcome back to the deep dive. Today, we are staring down the barrel of a condition that is, quite honestly, the stuff of nightmares for anyone in GI or acute care surgery.
Oh, absolutely.
You know those cases that they ruin your weekend and keep you up at night wondering if you made the right call?
This is the one. It is the ultimate high-stakes game of poker with a patient's physiology.
We aren't just talking about a big colon here. We are analyzing a complete catastrophic breakdown of neuromuscular integrity.
Right.
It's a surgical emergency where the mortality rate can jump from a manageable 7% to over 27%.
Or even 50% if you get a perforation. It just skyrockets depending on how fast that team moves.
So today we are unpacking toxic megacolon.
A true race against time. And what makes toxic megacolon, or TM, so challenging is the camouflage. It often masquerades as just a severe case of colitis.
Until it crosses a line.
Very specific, very dangerous line. It's the silence of the bowel before the storm.
That silence is terrifying. We are going to get into exactly what that sounds like or doesn't sound like in just a moment. But before we start peeling back the layers here, I have to get the housekeeping out of the way. While we are diving deep into the pathophysiology, the criteria, the surgical nuances today, this content is for reference and educational purposes only.
That's right. Medicine is nuanced. Please always follow your local institutional guidelines and protocols in your actual clinical practice.
So don't operate based on a podcast.
Please don't. A good rule for life.
Definitely. So let's get into the definition. What exactly distinguishes toxic megacolon from just severe inflammation? Because mega implies big, but toxic implies something much, much worse.
It's the combination that kills. Our sources define it very specifically. Acute colonic dilation exceeding 6 centimeters. But, and this is the key, it must be accompanied by systemic toxicity.
And that systemic toxicity part, that's the real differentiator.
Absolutely. You can have a dilated colon from a mechanical obstruction, a tumor, a volvulus, and while that's bad, that is not TM. TM is a distinct physiological collapse where the organ is essentially poisoning the host.
So our mission today is to walk surgeons and doctors through that collapse. I want to understand the biology, why a colon just paralyzes itself, but also the diagnostic criteria. We've got Jalen, Oxford.
And maybe most importantly, identifying that window for medical management and that point of no return where surgery stops being an option and becomes mandatory.
Let's start with the why. The pathophysiology. I was reading through the source material and I was just fascinated by the mechanics of this. It's not that the colon is blocked, it's that the muscle itself effectively quits.
It just gives up. It shuts down.
Yeah.
At its core, TM is caused by transmural inflammation.
So transmural, meaning it goes all the way through the wall.
Exactly. In standard colitis, you might have mucosal inflammation, surface level, like a carpet burn on the inside.
Right.
In TM, the inflammation punches deeper, right through to the smooth muscle layer, and that disrupts the entire neuromuscular integrity of the colon.
And the sources point to a specific chemical cascade. It's not just inflammation in general, right? There's a specific bad actor.
There is. It's a cytokine-mediated process, a huge surge of interleukin-1 beta. But if you want to identify the real villain in this story, mechanistically, it's nitric oxide.
Nitric oxide. I usually think of that as a vasodilator. Good for blood flow, right?
In the vasculature, yes. But nitric oxide is also a potent, smooth muscle relaxant. The inflammation triggers an excessive, uncontrolled release of nitric oxide right there in the bowel wall.
So the body is chemically forcing the colon to relax, but to a pathological degree?
It inhibits the smooth muscle tone entirely. The colon dilates not because it's being blown up like a balloon, but because it physically loses the ability to contract.
It goes limp.
It goes limp. And to make matters worse, other things like hydrogen peroxide get involved, but that nitric oxide release is central to the paralysis.
And that's where external factors can just pour fuel on the fire. I was struck by how many common medications can actually push a patient off this cliff.
This is a critical point for any clinician listening. If you have a patient with severe colitis, you have to be so careful. Antimotility agents, opioids, anticholinergics.
All dangerous because they inhibit peristalsis.
Precisely. You're taking an organ that's already struggling to contract and you're sedating it further. You are practically inviting the megacolon to form. Giving loperamide for bloody diarrhea might stop the flow, but it might also kill the colon.
What about electrolytes? I saw hypokalemia flagged as a major risk factor.
A huge role. Potassium is essential for muscle contractility. If your patient is hypokalemic low potassium, Their smooth muscle is already compromised. It just makes that nitric oxide paralysis so much easier to achieve.
So who is the typical patient here? Is this strictly an ulcerative colitis problem?
Historically, yes. UC is still the biggest culprit. It accounts for about 50% of all cases. But the landscape is it's shifting right under our feet.
C. diff is climbing the charts.
Rapidly. C. diff is responsible for anywhere from 20 to 50% of cases now, depending on the study you read.
And that's because of hypervirulent strains. I saw ribotype 027 mentioned.
That's the nasty one. These strains produce massive amounts of toxins that just trigger a severe pseudomembranous colitis. It eats through the bowel wall just as effectively as UC.
And Crohn's?
Less common, maybe 10 to 30%. But no matter the cause UC, Crohn's, C. diff, the danger is the same. The mucosal ulceration thins the bowel wall,
Creating a ticking time bomb.
It's the perfect analogy. As the wall thins and the diameter expands, the wall tension increases. That's Laplace's law in action.
Tension skyrockets.
Until eventually it fails, and you get a perforation.
And as we said, if it perforates, mortality goes from bad to catastrophic.
It basically doubles. You do not want to be operating on a perforated TM.
Okay, let's move to diagnosis. You're on the floor, you've got a patient with colitis. What does that transition to TM actually look like?
It can be deceptively subtle. It starts with classic colitis bloody diarrhea, abdominal pain. But then the picture shifts. You get distension, obviously, but the sign that should make the hair on the back of your neck stand up is silence.
The silence of the bowel. That sounds poetic, but it's actually a terrifying clinical finding.
Absent bowel sounds. When a patient with severe colitis suddenly stops having bowel sounds, it means the colon has stopped moving.
And a lot of junior doctors might mistake that for improvement. Oh, the diarrhea stopped.
Exactly. They think they're getting better, but no, the diarrhea stopped because the gut is paralyzed. It's a sign of impending doom.
And the patient's mental state changes too.
Often, yes. Confusion, delirium, that's the systemic toxicity hitting the brain.
So to make this objective, we have checklists. Let's break down the Jalin criteria first.
Right. Jalin is the foundation. First, you need radiographic evidence. Colonic dilation greater than 6 centimeters in the transverse colon.
But dilation alone isn't enough.
No. For Jalin, you need that dilation PLUS at least 3 systemic signs. So fever over 38.6 Celsius, tachycardia over 120, a white count over 10.5, and anemia.
A very clear checklist.
A rigorous checklist. You can't just eyeball it.
Okay, and then there's the Oxford criteria. It's similar, but it adds one specific marker.
It has hypoalbuminemia, specifically an albumin level less than 30 grams per liter.
Why albumin?
It's a marker of how severe the inflammatory state is. The gut is just weeping fluid and protein at a massive rate. If albumin is tanking, that patient is incredibly sick.
Okay, we have our criteria. Let's talk imaging. What are we ordering?
You start with a plain abdominal X-ray, the AXR. You're looking for that 6 centimeter dilation, but you're also looking for thumb printing.
Describe thumb printing for us.
It's mucosal edema. The folds of the bowel are so swollen they look like someone pressed their thumb into clay along the wall. You also see a loss of haustra, so it just looks like a smooth lead pipe.
And you mentioned serial X-rays are key.
Never just one. Get them every 12 to 24 hours. You need to track the velocity of the change. But while X-ray is good for monitoring, the CT scan is really the gold standard for detail.
Why is CT so critical if the X-ray shows the dilation?
Because the CT sees what the X-ray misses. Wall thickening, fat stranding, ascites. But crucially, it detects microperforations that aren't big enough to show free air on a plain film yet.
And there was one CT sign mentioned in the material that sounded particularly grim: portal venous gas.
Yes. If you see gas in the portal vein, that is a very, very bad sign. It implies the mucosal barrier has completely failed. That patient is an extremis.
Let's touch on labs quickly. We mentioned leukocytosis, but what's the lab value you watch like a hawk?
Lactate. A lactate over 4 millirol is a highly specific predictor for perforation. If lactate's climbing, your window is closing. The gut is dying.
And for C. diff?
Stool toxin PCR. Gold standard. You have to rule that in or out immediately because it totally changes your antibiotic strategy.
All right, let's say we've diagnosed it. We're in the medical window. We're trying to save the colon without surgery. What's the immediate game plan?
Immediate admission to ICU or a high dependency unit. This is not a ward patient.
Right.
You make them NPO nothing by mouth, and you place an NG tube immediately for decompression.
Just getting the air out.
Taking the pressure off is vital. Then, aggressive fluid resuscitation. Correct their potassium, correct their magnesium.
Pharmacologically, what are we hitting them with?
If it's IBD, you start IV steroids immediately. Hydrocortisone 100 milligrams every 6 hours is standard. You're trying to put out the fire.
And antibiotics, even if there's no confirmed infection.
Non-negotiable. The risk of bacterial translocation across that thin, weeping bowel wall is massive. You need broad-spectrum coverage.
And if you even suspect C. diff,
You add oral vancomycin immediately. Don't wait.
what if the steroids don't work? The sources mention rescue therapy.
Right. If you're 48 to 72 hours in and there's no response, you can consider cyclosporine or infliximab. They have a response rate of about 60 to 80%.
But there's a catch there, isn't there? The timing.
The catch is time. If you wait 3 days to see if steroids work, and then another 3 days for infliximab, you might have missed the surgical boat. You cannot wait too long.
And just to reiterate the stop list, what do we absolutely avoid?
No opioids, no anticholinergics, no antidiarrheals like loperamide. And an expert warning here, do not perform a full colonoscopy.
Why not? You'd think you'd want to see how bad it is.
The risk of perforation is just too high. The wall is like wet tissue paper. If you pump air in there, you will pop it.
So what's the limit?
A gentle, flexible sigmoidoscopy with minimal air. Just enough to see what's going on, maybe take a biopsy and get out.
Okay, let's unpack this surgical pivot. This feels like the hardest decision. When to cut?
It is. The data suggests delaying surgery more than 5 days triples the mortality rate.
Triples.
You have a very finite window.
So what are the absolute triggers? When does the debate end?
Absolute indications are straightforward. Free air perforation, generalized peritonitis, uncontrolled hemorrhage. You don't debate, you operate.
And the gray area, the relative indications.
It's if the patient is deteriorating despite medical therapy, or simply if there's no improvement after 24 to 72 hours.
And how do we define no improvement? Because that can feel subjective.
You have to use the numbers. If they're still having massive stool output, if the dilation is worsening on x-ray, or if that lactate is rising, you have to move.
You can't just sit and hope.
You can't. Before they roll into the OR, you resuscitate to a MAP over 65. Correct any coagulopathy. And practically get the stoma nurse involved to mark the site.
That seems minor in an emergency, marking a site.
It sounds minor, but a poorly placed stoma impacts quality of life forever.
Yeah.
If it's in a skin fold or their belt line, their life will be miserable. Take the 5 minutes.
Let's go into the OR. The procedure of choice is a subtotal colectomy with end ileostomy. Why that specific surgery?
It's the Goldilocks procedure for this emergency. You remove the diseased organ, the colon, which removes the toxic load.
Yeah.
But you leave the rectum.
Why leave the rectum?
2 reasons. 1, it leaves the door open for future restorative surgery, like a J pouch. 2, doing a total proctocolectomy, removing the rectum too, is a much longer, bloodier surgery. You want to get in, get the colon out, and get out fast.
What about something less invasive, like a loop ileostomy?
It doesn't work. You're just diverting the stream, but leaving a septic tank inside the abdomen. The failure rate is 86%. You have to remove the source.
Okay, there's some technical nuances here I found fascinating. The sources say you decompress before you even try to move the colon.
This is critical. The colon is huge, distended, and the wall is incredibly fragile. If you try to grab it while it's fully distended, it will burst in your hand.
Spilling stool everywhere.
Exactly. So you use a needle or a rectal tube to gently deflate it first. You reduce the tension so you can handle it safely.
And this is usually a big open surgery, right? A laparotomy.
Usually, yes. A big midline incision. The colon is often too large and friable to handle safely with laparoscopic instruments without rupturing it.
What do you do with the rectal stump?
You can either bring it out as a mucus fistula, which is a small opening on the skin, or oversew it and leave it inside as a Hartmann's pouch. The goal is just to prevent a stump blowout later.
Okay, the aftermath. Patient survives surgery. What's the ICU stay like?
They're in ICU for 24 to 48 hours. The immediate challenge is often the stoma output. We see high output stomas more than 2 liters a day in 20 to 30% of patients.
That is a massive amount of fluid loss.
It is. They can dehydrate incredibly fast. You manage it aggressively with fluids and eventually drugs like loperamide, but only after the acute phase settles.
Any other big complications to watch for?
Rectal stump blowout happens in about 5% of cases. Pelvic sepsis, 5–10%, and VTE blood clots. The incidence is around 20%.
20%, that's incredibly high.
It is. These patients are incredibly hypercoagulable because of the inflammation. Aggressive prophylaxis is mandatory.
Now, looking further down the road, the patient has an ileostomy. Is that it for life?
Not necessarily. And that's why we save the rectum. Once the patient is fully recovered, usually 3 to 6 months later, they can be evaluated for an ileal pouch anal anastomosis, a J pouch.
And the quality of life after that?
Generally quite good. The SF-36 scores are comparable to the general population. There's risk of pouchitis, sure, but for many, it's a return to normalcy.
Which brings us back to those heavy mortality stats we started with.
It is. The data is clear. Surgery halves mortality compared to prolonged medical failure. We're talking roughly 16% mortality with timely surgery versus 40% or more if you keep pushing medical therapy that isn't working.
That really drives home the ticking clock theme of this deep dive.
Absolutely. The biggest mistake is hesitation. You are not giving up on the patient by removing the colon. You are saving them.
So let's wrap this up. We've covered the biology of the paralyzed muscle, the J-Lon criteria checklist, the dangers of opioids, and the absolute necessity of the subtotal colectomy.
If you take one thing away from this, let it be this. Respect the silence of the bowel. When the colon dilates past 6 centimeters and the sounds stop, you are in a different territory. Do not fear the colectomy.
It saves lives.
It saves lives.
And here's a provocative thought to leave you with. The source material highlights that while we focus so intensely on saving the organ, the data shows surgery often provides a better quality of life faster. In this era of biologics, are we sometimes hurting patients by hesitating to operate? Are we letting the perfect be the enemy of the good?
That's the question every team needs to ask themselves during that 48-hour window.
Indeed. Listeners, if you found this deep dive useful, please share it with at least one colleague or friend in the medical field. Help spread the word.
It really helps us out.
And don't forget to check out our YouTube channel and social media pages for more visual breakdowns of these topics. Thanks for listening, and we'll see you on the next deep dive.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.